Moving on to the next session, we have Pedro Vaz from Champalimaud Cancer Centre. The talk title is A Pragmatic Approach for Lung Cancer Screening Using Exhaled Breath in a Clinical Setting. So Pedro's held positions as staff researcher at the University of Lisbon at the ISIS Neutron and Muon facility. He's also served as scientific director at SGS, Portugal, and Inspection Quality Insurance Multinational. Pedro joined Champalimaud Foundation in 2008 as a researcher leading the development of early diagnostics for lung cancer using exhaled breath analysis. He's now head scientist at Telspec Inc. as an elected fellow of the Royal Society of Chemistry. So over to you, Pedro, for your talk.
Good morning. I would like first to thank the kind invitation to deliver this presentation, and I hope this can be interesting enough to promote some discussion later. I am presenting our case of using VOC analysis for lung cancer screening under a clinical setting. Within this perspective, my talk will focus on how to deal with the context, the facts, no one can be left behind, the approach, and results so far. So the first part will be how the context has made the setup for the story I'll tell you. Hippocrates, making stand to his role as father of medicine, was the first one to propose that diseases would smell. And he was right after all. So there are many known diseases that exhale scents. For instance, you know TB, chronic kidney disease, Parkinson, gum diseases, diabetes, phenylketonuria, or any others. And back in the 18th and 19th centuries, doctors made use of their sense, taste, olfaction, etc., to diagnose these patients with some of these diseases. And you know that odors can be found in breath, urine, across. And you might have also come across with the story of Oscar the cat about being able to anticipate the death of people at the Rhode Island hospital. So this takes one to think whether death has its own scent. Now, taking you to the second part of the journey, the facts that confirmed what empirically people were already doing in the past. 2 years ago, the CRUK issued this fine document where the upcoming strategy for fighting cancer was delineated. The document recognizes that early detection and diagnosis of cancer can yield better survival chances. ED&D should be a priority. Cancer incidence is also growing, and this cannot be achieved with present techniques. So the bottom line is that innovation is needed. So why do we need advancements in ED&D for lung cancer as we do in many other diseases? Take these infographics. Per each 1,000 patients with criteria for screening, meaning above 50 years old and with 20 pack year smoking history, there will be two groups. The first one with 180 individuals in pink, which will need extra scan, meaning they will receive 4 scans in total, which they are already having an increased radiation exposure. And another one with 41 individuals, which will be diagnosed with lung cancer. Now, look at the numbers below. In the first group, 13 of those, beyond the extra radiation, they will need invasive procedure to rule out lung cancer. And an outcome of this can be death. So on the second group, a few, 4, will never be developed, and only 3 out of the starting 1,000 individuals will be prevented from dying from cancer. So, and one needs to think of the outcome of this approach, and we are still leaving out those with without criteria for screening, meaning the never smokers. In this way, as The Economist mentioned in 2019, screening is a good thing. The question is that as it is designed presently with today's tools, it doesn't fit everyone. Sure that clinical trials have demonstrated usefulness of screening, LDCT can effectively be resourceful to implement screening programs, but only in those with risk criteria, and there is the burden of false positives, as we've seen before. Yet, incidence is rising in never smokers. How do we cope with them? Despite LDCT's low radiation, it should not be used routinely in annual screening of those individuals. So, what do we do with those without screening criteria? Well, where lung cancer is showing worrying incidence rates. Somehow, for these population groups, we are stuck in no man's land. What we know from the past study is that using VOC-based tests using Exhale-BREF is that they are excellent at ruling out diseases. See, for instance, this red box in the image. So these tests have high negative predictive value, which means being non-invasive and radiationless, it opens perspective of using this as an easy-to-use and cheap solution that can be implemented at points of care, even in populations without criteria for screening. Entering now in the first part of my talk, this is where we change the paradigm by demonstrating how a non-invasive and radiationless approach can be useful to reach population groups that could never be eligible for lung cancer screening with present techniques. I name this "No One Can Be Left Behind." So the concept is simple. This is just a refresher. We have our own genetics and biochemistry in our bodies, which then can be modeled to each one's exposure and lifestyle that shapes ourselves into unique individuals as given by our phenotype. Furthermore, our metabolic processes, which are then adapted, will yield excretion of those of the metabolites coming out of those metabolic processes. And this will mirror the organism's condition, allowing to understand its health condition at a given point in time. We already know that the different body fluids are rich in organic compounds. Take, for instance, this graphic where the families of chemical compounds are stripped down across different body fluids. So the first thing coming out is that each matrix is comprised of several families of chemical compounds. And the second thing, which are sometimes common across the different fluids, and second is that their relative concentrations are variable. So this is a challenge if one needs to analyze this or use this as a screening or diagnosis procedure. Then again, for instance, sticking with non-invasiveness as a motto, breath and urine are the holy grail of body fluids. They will be always available and ready for screening. Focusing on breath, it is in the lungs where a lot of action happens continuously. As the image shows, not only does the exchange occurs there between inhaled air and the circulation, but one must account for all the other local processes, including microbiota, local cell metabolism, and exchange with local tissue. So this means that breath is the ideal channel to probe the body's condition, specifically lung cancer, although this is not simple. As such, the concept of using Exhale-BREF as a matrix for lung cancer screening is based on the fact that we know that lung cancer at early stages is very difficult to detect due to the lack of clinical manifestations. On the other hand, we know that tumor cells undergo metabolic changes. So using exhaled breath could be an excellent way of assessing these metabolic changes, which could turn out in a very simple test that is non-invasive and could easily and cheaply allow us to assess this. So this looks really exciting. Next, the difficulties are not simple either. For instance, the origin of various VOCs correlated with cancers is not fully understood. On the other hand, several VOCs were detectable or are detectable in more than one cancer. We have to deal with environmental exposure, which will affect the phenotype. There are confounders and puzzling situations that we poorly understand, and the standardization, validation, and quality control pose all of them challenges. So this is still exciting. And once you have overcome all the previous obstacles, the challenge gets no better. There are patient-related factors such as the exposure from the environment, whether they smoke, whether they use oral hygiene, diet, and then you have clinical related factors, medication, whether they have performed invasive tests prior to the breath collection, the human factor between the patient and the breath collection system, which fraction of breath is collected, how do you manage samples after analysis. There is still a large variability in published sets of biomarkers for the same disease, and we still don't understand the metabolic pathways completely. And once we do this, then we might come somewhere. An example, Professor George Hanna published this remarkable paper in 2019. If you look at the tables, the message here is lack of consensus, even within studies screening for the same disease. For instance, for lung, some studies reported as low as 5 patients, which tells you everything. In that paper, Professor Hanna assessed a large number of critical points that should be key when using analysis of VOCs, either from urine or breath, for cancer screening. So the message, put simple, is lack of standardization across studies. Just before that paper, the ERS issued a technical standard that set grounds for implementing the use of exhaled breaths in lung diseases, including cancer. Again, the message here is you need to standardize as much as possible. Once again, remember, if you can standardize in exhaled breath test, it can be excellent at ruling out the disease. Our approach. So we came late to the race, and our challenge was to ask ourselves, what could we do differently? We took a lot of time going through the literature, assessing bottlenecks and difficulties, and came up with how we could set our own solution. What we know from past studies is that there was a lack of standardization. At the same time, there were issues with quality control, namely concerning biomarker consistency and coherence, which was lacking. We therefore made the question to which we need an answer. Does this person has lung cancer? And this is driving our research in a clinical setting. So let's make an exercise. Think of 3 fragrances, similar, from the same brand, but with their own differences. On the left, you can see a strip down of their chemical components. Please ignore the last 8, as they will be the colorants. So as you can see, they look similar despite their slight differences. So which means that these slight differences will yield to each one of them their character, and that's why we sent each one of them differently. So the bottom line here is that we can recognize a smell or a scent as being comprised by a pattern, but without actually knowing the components of that pattern. And this is what is driving us in terms of our approach towards lung cancer screening with breath analysis. The study pipeline develops across these steps, from the volunteer enrollment down to the profile classification. It's a two-branch study comprising the control group without any known disease of cancer, and the lung cancer group, which was previously diagnosed. They are enrolled, they sign their informed consent, and the patient is given the preparation instructions for the day of the test, and the test is itself scheduled. On that day, after the collection of the sample, it is analyzed as soon as possible, usually within 30 minutes time. So when running the samples, our quality control procedures include blank checks and TD tube reconditioning check for the same batch used in the sample collection. And then afterwards, the data set follows its own path with filtering, statistical analysis, and down to the profile classification. Now I'll show you some results so far based on what we achieved. The study provided us with some promising results, mirroring the care taken with all the critical points that we tried to assess and mitigate. From the whole data set, we divided this into the training set, comprising 70% of the original data set, and the remaining 30% of the data set were used for validation. So the first model used was an elastic net regularization algorithm that allowed us to reach a precision of 69%, which is encouraging, of course. With this model, we achieved an area under the curve for the ROC curve of 0.82. And on the right side, you can see a visualization of the confusion matrix obtained for this model. Data from the confusion matrix using this method allowed us to calculate these parameters, which, not being outstanding, they seem fair. This also means that we need another model better than this one. We then moved to support vector machine algorithm, and as you can see, the change is dramatic for the better. We now reached a precision of 80% on the validation set, again maintaining the 70% of the original data set for training and the remaining 30% for the validation. The ROC curve now displays an area under the curve of 0.85, which is not immensely better. On the right side, you have a visualization of the confusion matrix. New results with this method allow calculation of these parameters again, and as you can see, they have increased or improved dramatically. This shows us that we are on a good way towards improving this, and we just need to increase the size of our data set to improve the statistics. Comparing our results with those from present screening methods, LDCT, we can see that our values, especially those from SVM, show an overall better consistency than evidence across the LDCT randomized studies. And this includes NLST and Nelson studies. I would point you to the positive predictive value, which in our case we achieved 77% in the validation cohort, and the randomized studies for LDCT screening achieve an average of 21%, with the highest one being reported as 44%. Yet, our concern is still the NPV, the negative predictive value, that needs further improvement. But we are confident that we will get there. Take-home messages. VOCs for lung cancer screening or any other disease is not a straightforward business. Another question that we raise is, do we really need to know the metabolites for a clinical setting? A breath analysis screening tool, if implemented, will need customization and updating. Standardization and validation and quality control across the whole process is key. Patient preparation is key as well. And this, being non-invasive and without radiation, can be used at any population, that even without criteria for screening, including we can ask ourselves whether we can use smell through VOC analysis as a screening tool. I really believe so, as I think most of us present here at this conference still also do. There is still a long way down the road, but I think that we will get there. Finally, I need to show you and thank the team that is making this possible. So Champalimaud Foundation, our institution, the lung unit, which is shown here, the clinical investigation unit, nurses, patient management, and the volunteers, of course. And thank you for being present.
Thanks, Billy. It's really a pleasure to be here and again have delivered this talk. And I've seen a few questions have popped up, so yeah. I'm really happy to answer them.
I wonder if I could kick off with one that I had. So
yep.
George Hanna's paper I thought was great, and just like eyeballing that slide, it looks like there's about 50 papers there related to oncology where you get massive variation in what's reported, sensitivity, specificity, very little agreement between any of the reported compounds there. Do you think that endogenous VOCs will ever be able to solve the early detection problem in cancer when you go into independent validation next?
Well, this may be semantics, but or demagogy, if you wish. Eventually, yes. As I said, once the tricky question that we need to ask ourselves is, can we manage to know which are the metabolic pathways that we really need to know? And if yes, if we can manage that, I think there's a whole new world that we can really go for endogenous metabolites. Now, that will not be an easy quest. And I think, for instance, if we think then of not on oncology, but the work you guys have been doing at Halstone with the exogenous ones, I think that's already starting to show something on, for instance, inflammatory diseases or any other diseases. So I'm not sure. Well, to put it more simple, I think endogenous metabolites can be the answer to an oncology problem in terms of screening or diagnosis. But I think they will give you only as a pattern of relative concentrations, as each tumor, depending on its primary location, will have its own microenvironment, and that will tailor what you will get in an analysis.
Great, thank you. You also touched on standardization and the importance of standardization. I was wondering if you could elaborate a little bit further on that topic.
Sure.
We've got some Q&A later on today as well on the topic, so I'd love your thoughts on that.
So as you mentioned, Hannah's paper, you see all those variances. So what I mean, and I saw one of the Q&A, one of the questions here was about volunteer standardization. So actually it's not volunteer standardization, is actually the standardization once the volunteer is enrolled. So we try to standardize as much the volunteer preparation prior to the breath collection, and just as Giuseppe showed earlier a while ago, so people will not have lipstick or perfume, so something like that, fastening times. So we try to standardize everything as much as we can, and even the collection place and the collection conditions, analysis conditions. So we try to keep this as much as possible homogeneous and coherent.
Got it, thanks. One question here relates to the analytical approach. So could you elaborate further on the actual analysis? So how the biopsies are analyzed, what systems you use?
So we use Alstone's Lone Star and the receiver breath collector. So this gives us a standardization across the process and across all the volunteers, either control branch or disease people. So of course you have confounders, because we always have, for instance, from the receiver, we have a background level of due to the masks, but these are known issues. So we just run between samples control charts and control sampling of what we think can be possible confounders. So even for each set of 4 tubes, TD tubes that we use across for a given sample collection, we run 2 blank tubes from that batch that we regenerated, so to be sure that the batch of regeneration was okay. So we try to control everything as much as we can, of course.
Brilliant. And we have time for one last question. So thanks for your talk. What are your recommendations regarding QC and analysis of breath samples?
So QC, as I said, so it's trying to and this is especially easy to follow. Well, at least I think it's easy to follow for analytical chemists, but maybe not for others. So as I said, we try to have the patients or the volunteers as much standardized as possible when they come. So we try to have several people trained to make breath collection and the analysis. So the other good thing is that we minimized not to complicate things about sample input when we analyze, and then when we extract data. We just try to use barcoding across all the process. So even the pseudonymization is barcoded, and we take advantage of the TD tubes from markets to be barcoded as well. And so we can track down if something goes wrong easily. So we try to minimize across as an holistic view of the whole process. And given the numbers we achieved, we think that if we can at least match LDCT performance, then we could just try to start thinking of replacing it in some cases.
Thanks again for the time today, Pedro.
It was a pleasure. Thank you, Billy.
Thank you. Cheers now.